I want to talk about congenital first.
Oh, okay.
Gastroschisis and then omphalocele.
Didn't we do gastroschisis already?
Yeah, I just want to compare. And Michel's diverticulum. Okay. Now to understand this, I guess I can. You see, the small intestine and large intestine during the fourth, fifth, especially during the fifth week, the liver and the small intestine enlarges so fast, especially the liver enlarges so fast that there's not enough room for what? For intestine within the abdomen. See, during the fifth week of fetal development, the small intestine, large intestine, part of the stomachs are herniated through umbilicus outside of the abdominal cavity, through umbilicus into the amniotic cavity. This is normal. So this is known as physiological hernia. Physiological hernia. Okay? Physiological hernia. Fifth week, abdominal content will leak or will herniate, will move out of the abdominal cavity into the amniotic cavity, and then before the 10th week, it will return back. All of us went through that. You just don't remember because you were inside, you were just a fetus. So once a fetus, and a fetus is a baby that's unborn, of course. Okay, 5th to 10th week, you can find abdominal content outside of the abdomen of a fetus. That's normal. It's known as physiological hernia, and it will return back before the 10th or the end of 10th week. Okay, why? Because the liver is growing so fast that abdominal cavity cannot accommodate the structure, so they have to herniate until the baby's abdomen becomes large enough so that they can take it back and accommodate it there. It's just simply because of lack of room. Okay, so liver grows faster than abdominal cavity. Therefore, some abdominal content have to be mislocated, pushed out of the abdomen through umbilicus. That's known as physiological hernia. Good? Are we good with this? Omphalocele is when physiological hernia does not return back. Omphalocele is when physiological hernia fails to return. So look, if I give you a CT scan or MRI imaging or some sort of radiograph or image of a fetus between the 5th and 10th week of fetal development, and you find abdominal content outside of the abdomen, that's normal. You will choose physiological hernia. Okay? But if I show you a CT, MRI, or radiograph of a fetus in the 20th week, and you see abdominal content outside of the abdomen, then it's omphalocele. It's abnormal. If the baby is born with it, of course it's abnormal. You don't see a baby. The only thing that's outside of the baby's abdomen is the placenta attached to the umbilicus, through umbilical cord. There should be nothing else. Everything should be in its appropriate location. So omphalocele is when the abdominal content does not return or fail to return to abdominal cavity after 10th week of fetal growth. Make sense? All right. There's nothing else. There's no defect. There's no bleeding. There's nothing like that. Yeah.
What's that covered up?
Now, of course, it will be covered with the amniotic sac. Okay, so it will be covered. Now, so that's omphalocele. Okay, that's omphalocele. Gastroschisis. So omphalocele. Now you can write between them physiological hernia. So make sure you know what is physiological hernia. In order to understand omphalocele properly, you should know physiological hernia. Okay. And of course, if a baby is born with omphalocele, you can place the abdominal content back into the abdomen and seal or suture the umbilical area, and it'll be back to normal. Okay, so it's okay. You can put it back. Yeah.
Omphalocele is usually near the umbilical.
It is through the umbilical.
And then, but gastroschisis is the one to the side, right?
Yeah.
Okay.
So now that's omphalocele. Make sure you know the difference between omphalocele and physiological hernia. It's the same thing. The difference is time period. That's all. It's exactly same thing. The difference is time period. Yeah. Physiological hernia is supposed to return back. It's supposed to go back to normal after the 10th week. If it fails to do so, then you call it omphalocele. Okay. So that's one thing. Now let's go to gastroschisis. If this is the baby, and here is the umbilicus. Okay. If abdominal content, let's say in this case intestine. Let's say the baby is born, and the intestine is outside, stomach and other content, and it's coming out through the umbilicus. It is omphalocele. Good? Okay. Now, see, abdominal wall is made of abdominal muscles, skin and fascia. Now, abdominal wall has these muscles known as transverse abdominal muscles, oblique abdominal muscles, external and internal. So sometimes these muscles do not form, and there's a defect parallel to the umbilicus, next to the umbilicus. Okay, not through the umbilical area. Okay, beside umbilicus, to the side, left or right side, don't matter. If that defect does not seal properly, if the wall is not formed properly, and there's a defect in the wall, let's say there's an opening. Okay, let's just choose one side, left or right, don't matter. Let's say there's a defect in that wall, it is not formed properly. So abdominal wall does not form properly, and now you have intestine leaking out of here, or herniating. I shouldn't say leak, or herniate. And let's say gallbladder and liver too. It's known as gastroschisis. The difference between gastroschisis and omphalocele is it through umbilicus or through other part of the abdomen? Regardless, in both cases, it's anterior abdominal wall. 100%. The defect is where? Anterior abdominal wall. In gastroschisis, it is next to the umbilicus. In omphalocele, it is the umbilicus itself. Now, in gastroschisis, the abdominal content is not covered with a membrane or skin. With omphalocele, it is covered with a membrane or skin or peritoneum. Okay, so you can see it that way. At the end of the day, remember, this is in both cases, it's not a big deal. When a baby is born, you should be able to repair that. If you don't repair it, the risk of rupture, infection, and a lot of things could happen. So you put it back into its place and seal the cut or the defect. Yeah.
For gastroschisis, the underlying cause of the actual muscle defect.
Yeah. And for omphalocele, is simply failure of abdominal content to return back to its normal location. There's no defect anywhere else. Yeah.
You said that gastroschisis is not covered by skin, by anything. It's not covered by anything. So it's bowel.
It's bowel, yeah. Yeah. Okay. All right. So that's these two. At the end of the day, repair is simple, straightforward, very easy. Now let's come to two of the most common congenital disease of GI in terms of the exam, not in terms of population. On step 1, you will see these guys for sure, these two. So we will spend a little bit more time on these two. Okay. Now, both are congenital defects. So all 4 of them are congenital defects. You know what? I can leave them. These are all congenital defects. We're done with these 2. So in Hirschsprung's disease, you know, the entire peripheral nervous system is made of what? What's the origin of nervous system, guys? Sam? Ectoderm. Neuroectoderm. The origin of nervous system. I'm not talking about brain only, spinal cord only, peripheral nervous system. I'm talking about the entire nervous system. The origin of nervous system is ectoderm, especially neuroectoderm. Are we good with that? Neuroectoderm will form 2 things: notochord and neural crest cells. Peripheral nervous system comes from neural crest cells. Peripheral nervous system comes from Neural crest cells. So we need to understand that. Neural. Can you guys see the color? Crest. Why crest? See, you know the ectoderm was a straight layer at one point, huh?
My eyes.
It hurts your eyes? That's why you took your glasses off? Okay. I just asked you if it hurts your eyes. You said no.
I thought, somebody was saying my eyes.
You watched the video. Yeah, I have to delete that video. Look, initially it was a straight flat layer. Okay, and this layer then can fold on itself. Will start folding. Okay, when it starts folding, then the area of fold can initially close and it'll form a tube. And this is known as neural tube. Neural tube. Neural tube. Okay, the neural tube gives rise to CNS, central nervous system, spinal cord, brain, and brain stem. So the neural tube become that. The crest of these folds, will become neural crest cells. Neural crest cells. Again, they're the same thing as this. It's still ectoderm, but they specialize and they become neural crest cells. Now you shouldn't be surprised with that, because essentially the embryo was only a single cell. In that single cell, an egg became 2 cells, 3 cells, 4 cells, 8 cells, 16, 32, 64, 128, and blah 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 blah. Right? It duplicates each time. And then of course then that cells will specialize. Some will become heart cells, some will become this, some will become that. You shouldn't be surprised. It shouldn't be difficult for you to understand. If a human being can start a single cell and become this 1 billion cell organism, or even more, I don't know how many cells, then you shouldn't be surprised that neural crest cells could develop. Of course it does. And you don't ask questions beyond that, because you'll confuse yourself. Neural crest cells are specialized neuroectoderm cells that will form into what? Peripheral nervous system. Done. Don't worry about the mechanism. Oh, where did they come from? Where did they come from? And then you're going to say, where's the egg come from? And then you're going to say, what is, an egg? Where did the chromosome come from? And what's each chromosome? What is the electron? What's the neutron? How far are you going to go? So sometimes you have to just put a stop to your thinking and say, let me just accept this and believe it and move on. Don't give myself headache. Too much knowledge can be also painful thing. Okay, so if you ask and you're hungry for too much, this, what if that, what if that, that's the job of skeptical people. And for us to live properly, we cannot be so skeptical. We have to sometimes take information and take it as it is. And don't make our life miserable. We don't have the capacity to know everything. You will never will. At least I believe that. No human being will ever be able to, at least, in their lifetime, be able to comprehend everything. And if you're hungry for more information, you want to know everything, the reason you're not able to do it, because no human being can handle everything. And especially when it comes to, I'm being diverted now, especially when it comes to psychiatry, your mental behavior and belief, how you think and stuff. Don't always look for everything to know. There are information that will make you more stressful. Okay, so we want to know, we're curious. Especially when it comes about your friends, especially when it comes about your relatives, especially when it comes about your partners and blah 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 blah. If you want to know everything about another human being, you will suffer at the end of the day. You will. So just put a stop to it. In this case, neural crest cells, it's good enough for me. I'm happy with it. I believe there's such a thing called neural crest cells, and their purpose is to develop into what? Peripheral nervous system. Done. Done. That's it. I'm done. Okay. All right. Okay. Now, neural crest cells, of course, in the intestine, we have 3 layers. The entire GI tract has 3 layers, right? So now, there's one layer known as muscularis propria. Muscularis propria is a muscle. And for muscle to contract, the whole purpose of muscle is to contract. If muscles don't contract, who cares? Then it's not even muscle. The thing that makes muscle unique is its contraction. Its contraction. And the contraction depends on 3 things, if you remember. Innervation, nerves, calcium, and ATP. So without nerves, muscles cannot contract. that means this muscle needs nerve supply, right? So if it is, this muscle is not part of the CNS. That means neural crustal have to migrate from the origin. If this is neural tube, okay, next to neural tube will be aortic, and then it will be, let's say, the GI tube or gut tube. Okay, so in embryo you will have the neural tube, the most posterior structure, and then aortic tube, and then gut tube. Okay, so now that means these crustals have to migrate where? Into the gut tube, which is foregut, midgut, and hindgut. You remember that, and you know that neural crustal come from ectoderm. Where does the gut tube come from? Primitive gut tube. What tissue does it come from? Endoderm. Excellent. Endoderm. So it's not the same thing. So that means the neural crustal has to invade this endoderm and then become what? Myenteric plexus. So they will come and travel here. When they do so, and they will embed in this area, and they will develop and specialize into what? Myenteric plexus, Meissner plexus, okay, Orbach plexus, okay. Further, it will also give you the origin of number, cranial nerve number 10 or S 2, 3, 4, okay. So regardless, now the myenteric plexus is known as ganglia. They will form this ganglia, parasympathetic ganglia, not sympathetic. They'll form what? Parasympathetic ganglia. See, myenteric plexus, I have to give you one more thing. So this is good, just to kind of give you. How much do you know about autonomic nervous system, guys? Autonomic nervous system. Okay, so peripheral nervous system has autonomic nervous system. How much do you know about autonomic nervous system? Why is it called autonomic? Autonomy. It's free. I love freedom, right? It's free. You know, it doesn't depend on anything. It does things without your control. You know, which means your entire GI tract is supplied by what? Autonomic nervous system, except the external anal sphincter. Now, you don't tell your GI, you know what, guys? I had a lot of coffee, and you're having this bowel movement, and you're like sitting in a meeting and stuff, and it's making sounds like, shut up, you know, you're embarrassing me. You can't do that. They won't listen to you. Let's say you eat something. We talk about acute diarrhea, right? Remember fried rice? Let's say you eat reheated fried rice and you develop this diarrhea. And then, you know, you don't tell your intestine, no, can you just take it easy for a second? Let me finish something. You have to go, you have to go. So what I'm saying is the intestine is not in your control. Okay, it's not in your control. Internal organs are not in your control. They're under autonomic control. So the autonomic nervous system, what happened? The autonomic nervous system, we have to know something about it. There are two autonomic nervous systems. We need to understand them, at least in anatomy. One is sympathetic nervous system, and the other one is parasympathetic nervous system. And they're opposing in actions. They oppose each other. They oppose each other. Okay, they oppose each other. So they control. For example, if you have too much sympathetic input, you might have trouble. You might have increased heart rate, hypertension. And parasympathetic will say, you know what, calm down, dude. What are you doing to my body? You're making me nervous. Let's say for most of you guys, you see some beautiful creature. For those of you who are single, not for me and others. So for those of you who are single, you see some beautiful partner. You say, oh my God, this is my potential partner. Your heart goes boop, 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 boop. Your skin turns red. And then you feel like, oh my God, what if they see me? They're going to know right away that I like them. And then parasympathetic will come and calm you down. Calm down. It's okay. It's okay. So there's opposing groups. Okay. Now, sympathetic. Nothing else makes you laugh, I guess. I don't know. If you see, like, let's say you see a monster, sympathetic input will increase, and you're gonna run. If you're Ahmed, oh my God, you won't even see him. You've been Detroit. Oh yeah, Ahmed is starting a comedy club for school, and he's going to be the president of comedy club, so support him. Thursdays, every Thursdays. Okay. Now, the only comedies he can do is if they're related to medicine. Yeah. So make these things into jokes. Yeah. All right, now let's talk about, in this case, anatomy is important, not so physiology. Physiology of it is, of course, you know, flight or fight mechanism, rest and digest, right? We've discussed this many, many times. If you want to understand sympathetic, think of flight or fight. Exercise or coffee drinking are all the symptoms that are produced in your body, sympathetic. When you eat a lot of food, all the symptoms after eating are parasympathetic. Done. Okay, so think about that. Now, in terms of anatomy, each of these will have two neurons. Two neurons. Each of them will have two neurons. Sympathetic has a preganglionic neuron. Okay, a preganglionic neuron. And then it has a postganglionic neuron. So neuron 1, neuron 2. Parasympathetic also has two neurons. Neuron 1 and neuron 2. What's the difference? Just based on the structure. There you go. For parasympathetic, the preganglionic, ganglia means when the two neurons combine together in the peripheral nervous system, okay? Ganglia. Ganglia literally means synapses or cell bodies. So this area will be a ganglia, this area. Because the cell body of the second neuron is located here, right? So this is a ganglia. The two neurons synapse communicate. Now, in parasympathetic, the first neuron is long. The second neuron is what? Short. And the second neuron is so short, it's always located on the organ itself. It's always located on the organ. So in this case, the second neuron, the postganglionic neuron, so let me write down the names. Second neuron should be also called what? Postganglionic neuron. Post, it's after the ganglia. Ganglionic neuron. This, the first neuron is known as what? Preganglionic neuron. Good. Preganglionic neuron in parasympathetic is very long. Vagus nerve starts where? From the brainstem. Where in the brainstem? Medulla. And it goes all the way up to your rectum. Transverse colon. So it's long. It goes from here all the way to abdomen. That's long. One of the longest nerve in your body. One of the longest nerve in your body. You know? And then it will end on, it will synapse where? On the intestine itself. So when I say my enteric plexus, the second or postganglionic neuron is my enteric plexus. Okay? The second neuron or postganglionic neuron of colon is my enteric plexus. Of intestine, small intestine is my enteric plexus. Of stomach is. And of esophagus is the same thing. So this is my enteric plexus. Now, how do you develop that? How do you develop that? That means neural crystal must travel to the wall of intestine. And especially which region? Muscularis propria and muscularis mucosa. Okay, so those two regions must be invaded by neural crystals to form these ganglia. Excellent, excellent, excellent. Okay. Now the question is, what if neural crystals fail to travel to this region? Would you have the postganglionic neurons? No. And what would you call it then? Can you call it lack of postganglionic neuron? Yeah. Can you call it aganglionic? Yeah. So it's the same thing. Okay, so the term should not confuse you. At the end of the day, remember, now, the question here is, so if you're talking about colon, you can have neural crystals here, but this segment does not have it, and then you have here. What I'm trying to tell you, it could be only a short segment of a colon lacking ganglia, or it could be the entire segment, or it can be the entire colon. Of course, the severity will depend on what? The length of colon involved. Okay, so the underlying cause, number one, for Hirschsprung's disease is failure of neural crystals to travel. Failure of neural crystals to migrate. To migrate where? Into the intestinal wall. What intestinal wall? Colon. Specifically large intestine, colon. Failure of neural crystals to migrate into wall of a colon or a segment of colon. Okay, that's basically it. If you can remember that, then that means you have conquered this disease. The rest is up to you because you understand the purpose of it. That's all I would memorize. Now let's say if I memorize that, what is the end result? The end result would be a ganglionic colon or segment of colon. That's all.
It's congenital.
Uh-huh.
And it's congenital.
Yeah. Now there's the thing. So you have myenteric plexus here, you have it here, you have it here. Okay, and you have it here, and you have it here. But now this area does not have ganglia or does not have postganglionic neuron, postganglionic parasympathetic neuron. Okay, if they don't have it, what happens to that area? Would it be able, what's the purpose of having ganglia or neurons?
Muscle fire.
Peristalsis, contraction, movement, muscle contraction, muscle movement. But muscle contraction, the end result of that is the muscle contraction, skeletal muscle contraction is unique, it's different. But in the intestine, the muscle contraction results in peristalsis, wave-like contraction, organized wave-like contraction. The wave will start from here, keep going down or along the length of intestine, starting from proximal, moving towards the distal, always, not other way around. For example, the wave of contraction should push stool away from stomach towards anal canal, not the other way around. It's not a vacuum suction that stool will be pushed from anal canal all the way to stomach. Does it make sense? So this peristaltic wave is unidirectional. It always goes in direction from proximal to distal. If a segment of colon does not have this ability to cause this wave, that means the wave will come right here and it will stop. So this area will be usually collapsed. This area will be collapsed. It will be closed. It will be stenotic.
Would this be another double bubble sign?
Not really. You could, but it's difficult to see because it's so twisted, the colon. Okay, so now what are you going to see? That means you cannot pass stool. The end result is obstruction, obstruction, and obstruction, and obstruction. And guess what? The aganglionic segment can increase in size. Sometimes in children it's okay. Later on, usually it should be, the symptom should appear after 2 weeks or something. But sometimes the patient or the baby is asymptomatic for 5 years. Okay, for 5 years, because then they don't eat so much solid. When it's switched to solid, the symptoms will increase. Especially in the first few weeks of life, it's mostly liquid stool. I mean, those of you who have seen babies, they don't produce solid stools, so it wouldn't be a problem, even if it's there. So all of this depends on what? On the extent of aganglionic segment. If it's longer, more symptomatic, severe. If it's just a short segment, okay. All right. So the end result will be what? Constipation, constipation. Now, what will happen to the proximal segment? The segment that's proximal to this area, it will dilate. In the segment that's distal, will be narrow and collapsed. Because stool is accumulating and accumulating and accumulating.
Looks like a mushroom.
Maybe Thai. I don't know, I'm just making up stuff. Anyhow, so now, so there will be obstruction. There will be failure to pass stool for this baby or child. Okay. Now, earlier on, you see, that means you can stimulate the proximal segment. It goes through peristalsis. The distal segment cannot be stimulated because peristalsis also responds to what? Contact. Contact. When stool contacts the internal layers, it causes distension. Peristalsis is stimulated. So the distal segment, there's no way of stool going there, let's say. So maybe if you insert a finger with, of course, the gloves on, and you stimulate the distal segment or anal canal, the child maybe after a few seconds have propulsive diarrhea or push of stool. So you can stimulate the segment and that will cause, and I'm assuming the segment is not large. So usually the question might even say that, you know, when you stimulate the anal canal or rectum, then the baby was able to pass stool. Not only pass, explosively pass it. Okay. Anyways, the child should be always brought in because of what? Constipation, obstruction, failure to pass stool. Okay. All right. Now, what would you do? What would you do? Huh? How would you let's start with diagnosis first. So a mother brings her child. Again, usually these are boys, right? All GI conditions are more common as a general rule. Defects, congenital defect in GI are most common in male. Okay. Let's say this mother brings her child, and what is she going to tell you? Oh, my child is not passing stool. My child is not passing stool. What would you look for on physical exam? Abdominal distension. Excellent. Abdominal distension. Obviously, clear cut. Abdominal distension. In some cases you might not see it, in other cases you will see it. So there's abdominal distension, and she's telling you that her baby is not able to pass stool for so and such long time or whatever, right? And you see there's abdominal distension.
Wouldn't be by touch harder.
Yeah, and the intestine should be rigid. In this case, you will call this toxic megacolon. Why toxic megacolon? It's mega because it's enlarged, it's dilated, right? Why toxic? It's at risk of rupture. That's what toxic means. It's not toxic because it's going to spread bacteria or this, not in that sense. It could rupture. When it ruptures, obviously will cause peritonitis, yeah? Okay. Toxic megacolon. Alright, so the boy or the baby in this case is unable to pass stool, constipation, and for such a long time. What are you going to do then? Barium. You can do barium. You have to be careful with barium too. Because what would barium do?
Add more pressure.
Add more pressure. It could put you at risk of rupture. And the baby will vomit it. And that'll be even worse. Okay? And a lot of physicians, sometimes they do that because they have no idea about this. Look, when you become a GI specialist and stuff, and you see stuff that are more common, you forget about common scenarios. Unless it's a teaching hospital. Teaching hospital, because you teach this, you know about it. But when you go to community hospital and stuff like that, then patients are not, physicians are not aware of it, or they forget about it because they don't. That's why CME, you have to continuously keep doing CMEs, right? To keep your knowledge up to date. And unfortunately, some physicians, and there's a lot of stories about this, they misdiagnose it and they indicate barium, and then makes things worse. So be careful with barium. You can do barium. It will show you toxic megacolon. But guess what? You can see toxic megacolon on what? On X-ray. On X-ray, you can see it regardless. Yeah, you can see on X-ray. So why do something more than that, if you can see it? Alright, so anyways, you should do abdominal X-ray. You can do barium if you wish, but it's not preferred. Especially if it's you can do that too. Now I'll come back to that. There's a thing. So if it's aganglionic region, how would you, the idea is, how do you diagnose aganglionic segment of intestine? At the end of the day, biopsy will help the most. Yeah. So now, rule number 1, whenever you suspect toxic megacolon, barium should be carefully used. Not just for this. The idea is not Hirschsprung's disease. The idea is toxic megacolon. When patient has toxic megacolon, you suspect, or abdominal distension, right? What is the physical sign of toxic megacolon? Abdominal distension. So if you suspect toxic megacolon, do not use barium, period. Don't take a risk. Don't take a chance. Okay, don't be brave. Don't do it. Yeah. Yeah, of course. I'll do X-ray regardless first. Okay, but whenever it comes to constipation, obstruction, we do barium first. But X-ray is easier, fast, cheap, not expensive, not invasive. You don't have to swallow anything. You don't have to, diet for 24 hours or whatever. Just do it simple, straightforward. But anyhow, so at the end of the day, the best test is biopsy. And biopsy will show you aganglionic segment. But what kind of biopsy would you do? Endoscopic? Okay. But make sure you do CT guided biopsy. Make sure you specifically take a sample of tissue from the aganglionic region. If you take it from a ganglionic region, then everything is normal. right? Okay. All right. Now digital rectal examination will not help. Okay.
Here,
Yeah.
does it look the young area? Does it look any different? I mean, as per the X-ray.
On X-ray, yeah, it will be narrowed. So you will see this. Let's say. So
Dense wise.
on what?
Dense wise. I mean,
Density?
yeah.
Yeah. Well, densities depends if you have their air or stool. You see, if the colon is empty, it's filled with air, it will appear dark. But when you see their stool and stuff, it will be slightly denser. You will see a little bit more pale. Because air on X-rays appear what? Dark, dark, dark. So it depends what you have in the colon or intestine. Make sense? Usually ascending colon, transverse colon are usually empty. Most of the food and stool is where? In the rectum and sigmoid colon, descending colon. So that area will appear like bright and or slightly more lucent. You can see it. The other areas will be dark. You won't be able to see much. Okay. So let's say ascending colon, transverse colon, descending colon. Okay. Now in this case, if you do abdominal X-ray, you might see that this area of the colon, let's see the segment is there, is narrowed. Okay, the aganglionic region. Okay, if it's this much, but if it's less area, this area might be normal. So there you go. So it depends on the segment, how much of the segment is actually, Very good, very good. Okay. Of course, take a sample from this region. Take a sample from this region. Yeah.
You said when there is no pressure from the stool itself, the ventricular doesn't work, right?
Yeah.
It restricts.
Yeah. So this will be collapsed, but again, you can still see it's enough size. Yeah.
Should I take really different sample from a different area?
No, you will do CT guided. The question is, if there's no contact, that means the part of the intestine will not be dilated. So what should I do? Should I take many samples? No, you can do ultrasound guided, CT guided biopsy. So you will see on a screen that this area is narrowed. So the scope will go as far as that, and you will take a sample from there. Okay. All right. At the end of the day, surgery is the only solution. What kind of surgery? Colectomy. Colectomy. Okay, so you'll remove that segment of aganglionic segment, and you will do anastomosis of the two distal segments, the proximal and distal segments. In a sense, let me go back here. So this is what you will do. You remove this region, and then you'll connect those two regions. Of course, that means because colon is long enough, you have to maybe pull it together, or maybe you have to sometimes even deattach from abdominal wall. You can do a lot of things. So don't think that you cannot replace it with another one. So you don't take a segment from somewhere else. You don't need to. It will be okay. Okay. Might give you diarrhea for a while because the length of colon is decreased, so absorption is decreased. So might give you diarrhea and bloating for someone. Eventually, your body will adjust. Okay. Okay. Let's move on to Meckel's diverticulum. Meckel's diverticulum. Now, descending colon and cecum. Cecum has a diverticulum. Think about it this way.
It's ascending.
I said descending?
Yeah.
Yeah, sorry. Ascending. Ascending colon. There you go. So ascending colon. Okay. The ascending colon will be also attached to a segment known as terminal ileum, right? And the terminal ileum there should be a valve over here. Let's use different color. Let's say yellow.
It's not sphincter.
There's a sphincter. Ileocecal sphincter. Very good. Okay. Now, see, part of the ileum, about 2 feet away from ileocecal junction. Okay, so about 2 feet away, roughly speaking, from this region. The ileum is attached to the umbilicus. It's attached to umbilicus. So let's say this is the umbilicus, okay? Let me do it this way so you can picture it in real life. In real life. Okay, so imagine this being the abdominal wall, green. This is the abdominal wall. So now the ileum is attached to abdominal wall through the umbilicus. And this region is known as vitelline duct. Vitelline duct. In fetuses, this is normal. Vitelline duct. Okay? So maybe I'll use a different color. Let's use green for this, okay? This area. Okay. Okay, so this is attached to the ileum. There you go, ileum. So there's that hole. That means things can leak out and so forth. But you know, in embryo this was normal. So now there's the thing. Vitelline duct. Few things can happen to vitelline duct. The vitelline duct normally should close. When it closes, it will become what? It will become vitelline ligament. It should completely close, degenerate. This opening will close completely and it will become what? A ligament.
How do you spell that out again?
Okay, VI. VITELLINE, vitelline duct. Okay. Okay, now this duct should degenerate in almost every human being. It's supposed to degenerate. It's supposed to close and become what? Ligament. Vitelline ligament. Okay, so one option is it becomes ligament. Good. Now in other cases this duct actually, let me see, what can I do? Yeah, in other cases it does not close. It closes only from here, only from the center. It closes from the center, right? Let's say it stays open. Let's say it doesn't close completely. So if it doesn't close, it's fistula. If it doesn't close, it's known as fistula. If it closes, it becomes ligament. It degenerates, it will become ligament. That's the best option. It's normal. All of us should have that. But there's another scenario that it does not close. If it doesn't close, that means there's a communication between your intestine and outside, or your skin, and then it's called fistula. Okay. Other option is it closes on the distal end right here. It closes here and it closes here. But guess what? Here it does not close. It becomes cyst. So it becomes a cyst. So that means there's some stuff that gets stuck there. It becomes a cyst. So it closes on both ends. It will close on both ends. So it closes on both ends. But in the center, it stays as a cyst, which is no big deal. I mean, you can imagine what could happen. You know what could happen with fistula. You know what's the big deal with ligament or cyst. The third option is, which is the most common option right now, it stays open on the inside, so it stays as a diverticulum. Diverticulum in this case would mean that this does not close completely. It only closes where? On the outside. It only closes on the outside. Okay, so there's no communication. It's not a fistula, but nonetheless it's diverticulum, just like the appendix. This is appendix. Okay. So let's say, you know what, I should use different color, but whatever, you get the point. So blue is closed, dark blue is closed. But now inside there's this empty cavity. Okay, it's empty cavity over here. This area is empty cavity. This is empty, so it's a diverticulum. That's known as Michel's diverticulum. So you can have Michel's fistula, Michel's diverticulum, Michel's cyst. If it's ligament, that's normal. Cyst will only have some fluid, something trapped there. It will just, that's about it. It will degenerate on its own. Fistula will leak stool, so obviously you'll be leaking stool to outside. Imagine the stool coming out of your umbilicus. Yeah, and again it could be repaired. Of course, it could be repaired. Okay. Now the third option is diverticulum. So this duct does not close completely. Only on the distal end it closes. The proximal end it's continuous with the intestine. So it will become a diverticulum. Okay, still no big deal. Now in certain percentage of these people, okay, in certain percentage of these people that have the diverticulum, they can also have two types of tissue found in the diverticulum. See, the tissue of diverticulum should be exactly the same as what? Colon, right? Intestinal epithelium, it should be exactly the same. But now in a percentage of people, there's two extra tissues. So usually they use the rule of two. The rule of two. 2% of the entire US population is at risk. So
Gastric and pancreatic mucosa.
very good. So 2% of 300 million is what?
600,000.
Yeah.
60,000.
600,000.
There you go. So you guys figured it out. I'll go with both of you. Both of you are correct. And it's 2 feet away from ileocecal junction. 2 feet away from this area. Okay, it's 2 feet away from this junction. Good. Now it has two types of tissue. Two types of tissue, and the tissue is usually gastric and pancreatic. It doesn't have to be gastric and pancreatic. Usually you'll find two types of tissue in this diverticulum. Okay. Now, okay, still no big deal. Unless there's gastric and pancreatic tissue, it's not a big deal. It's just a diverticulum like appendix. The problem is it could be at risk of infection and rupture. That's all. But now when you have gastric tissue is the problem. And those patients are symptomatic. Those patients who have gastric tissue in the diverticulum are symptomatic. Without the gastric tissue, normal tissue, they're asymptomatic. Okay. Now, if it's gastric tissue, what is gastric tissue? What are the cells found in the gastric tissue? Chief cells, parietal cells, mucus cells, mast cells. Good. Gastrin cells, right? But usually it's the parietal cells that gives you problems. So we're going to focus on parietal cells. Parietal cells. Now, parietal cells, what do they produce? HCl. And what will HCl do to this mucosa now? Yes. So the Michel's diverticulum will now bleed. It will cause erosion, ulceration of the diverticulum, and maybe around it too. So it will cause erosion, and that means the patient will always have bleeding issues. Bleeding.
Is it painful?
Sometimes, yeah. Bleeding, because the ulcer hurts. The erosion hurts, yeah. So bleeding. So the risk is bleeding. The complication of this condition is what? Bleeding and bleeding and bleeding. Okay? That's all there is to it. Make sure you're able to identify where exactly is the location, what are the tissue possible, and what is it? What part of the intestine is involved? It's ileum. Okay? It's ileum. And it's exactly where the superior mesenteric artery attaches. Okay, near the superior mesenteric artery, not the origin of superior mesenteric artery. It's where superior mesenteric artery actually attaches to the intestine or comes into the intestine. Okay, so for example, just to show you, Nina, you had a question. While I draw, you can ask me a question.
No.
No more?
I don't think so.
Okay. So if this is the intestine, the gut tube, we talked about foregut, right? Foregut, midgut, and hindgut. What artery supplies foregut?
Superior mesenteric. Oh, cilia.
Celiac trunk, and it'll give its branches, right? What midgut? Superior mesenteric artery, and then it will eventually gives its branches, right? But it enters right here in the center of midgut, and inferior in the center of here. Now, number one, you know, I will do this. Let me see. Hopefully, I can go back. There you go. Perfect. Superior mesenteric artery enters here, and that's where usually this intestine will loop around this area. It will loop like this around the superior mesenteric artery, and that's the area where the diverticulum is also common. Okay, so that actually then the midgut will rotate, and I'll talk about also midgut malrotation as well. Okay. All right. The next thing is midgut malrotation. So the midgut should rotate around the superior mesenteric artery. It should rotate around the superior mesenteric artery.
This is another disease.
It's another disease, yeah. So maybe we can think of it this way. In adults, the typical, you know, shape of large intestine is something like this, right? And then you will have the small intestine folded here, all here, and enter here. If you think about it, the entire right side, you know, the right side is occupied by who? Ascending colon. The left side is supplied by who? Descending colon. And then the upper part of the abdomen, transverse colon. Okay. This is the normal, you know, placement of colon. Okay. But what we can do is in midgut rotation. So I think I can do this. What if you find this midgut malrotation? Okay. So meaning that you should be aware of it at the end of the day. Whoa, okay, that's crazy. If you find transverse colon on the right side, it's malrotation. If you find rectum on the right side, it's malrotation, and so forth. Look for those things.
Everything rotate or just the colon?
Everything, even the small intestine with it.
It's kind of like status inversus.
But there is 270-degree rotation.
I was going to ask you, is it 270 or 90?
270. Okay. 3 times 90 is what? Yeah. Okay. All right. Yeah. And it's no big deal. The only problem is you might hear bowel sound and stuff like that in different areas. So
This is called malrotation.
malrotation, midgut malrotation.
Dr. Moneer, are we going to discuss appendicitis?
Oh yeah, good job. Crazy.
No way.
Yeah. Let's talk about appendicitis. Since we're talking about appendicitis, I think somebody mentioned hemorrhoids, and I forgot about it. So let's mention that. Anything else? Whatever you remember, just let me know, okay? Okay, appendicitis. See, appendix is a normal diverticulum. Meckel's diverticulum is abnormal. Meckel's diverticulum should not exist. It's failure of vitelline duct to go through degeneration. Okay, so that's abnormal, but appendix is normal. It's a normal. It's a, you know, the term diverticulum means a blind pouch. Okay, so in appendicitis, this diverticulum, all of us have it. Appendic diverticulum, all of us have it. It's normal. But what's the big deal? Well, the big deal is if people who are usually under constipation or hard stool or fecal matter, hard fecal matter, it gets trapped in there. If it gets trapped in there, it can cause what? Irritation. And that irritation will bring what? White blood cells. Thinking, you know, like your appendix feels a little bit irritation. White blood cells, you know what? I'm going to fix this. Let me go there. Let me fix the problem. Somebody's irritating my body or my diverticulum. So blood cells will come to that area. It all starts with what? Hard fecal matter. solid fecal matter, old fecal matter that is trapped there for years and days, whatever, and cause irritation. Okay. Now, if it's just trapped, no big deal. But the problem is it can cause irritation. Once it causes irritation, this irritation will lead to inflammation. Inflammation means what? Let's define inflammation. If this is just a diverticulum, what does inflammation means? So this diverticulum will now what? Swell. Excellent. It will swell. It will swell. So one sign of inflammation is swelling. The other sign is what? Warmth, redness, loss of function. And of course, all inflammatory tissue, when they swell, it becomes tender, it becomes painful. So at the end of the day, this is located in the right lower quadrant, and it's swollen. When you have swollen gums, does it hurt? When you have swollen lips, does it hurt? Any part of tissue in your body that's swollen, it hurts. So of course the appendix, they will hurt. It will hurt, and it hurt a lot. So that means when you move, when you eat, anything that will touch it, compress it, it will hurt. Okay. So at the end of the day, it's nothing more than inflammation of appendix. As a result, compression, touch, and distension, all of that will cause pain of appendix. Okay. So that's acute appendicitis. Now the complication that's worse is rupture. Yeah. You had it? How? You were probably young then when you had it. Yeah. It's usually in young people. Okay. Now there's the thing. So in appendicitis, it is sudden onset of what? Abdominal pain. My dear physicians, always give me specifics. Abdominal pain, headache, chest pain, leg pain, toe pain, whatever. When you say general pain, not a good idea. Get used to it. Okay? So abdominal pain, very good. Now this pain, where exactly? Abdomen is big. Left, lower, right lower, sorry, right, lower, quadrant. Okay. Is it always right lower quadrant? No. How does it start? Peri, umbilical, and then it spreads and radiates where? To right, lower quadrant. Okay, and then it essentially becomes right lower quadrant pain. Okay. See, appendix is usually forward, so back pain might not. Yeah. So now there is great. Now, do you guys know which way does the appendix point? Forward, backward, laterally, medially, combination of things.
Forward and downward.
In all direction, depends who you are. In majority of people, it forwards, medial, and forward. But there's a group of people where it points backward. So the pain could be tricky, right? It could be tricky, depending where it is, which way it's pointing out, which tissue is compressing it, and so forth. Okay. Now, abdominal pain of sudden onset, that is periumbilical and then radiates to right lower quadrant, accompanied by what? Fever and leukocytosis. If somebody has this, I'm not going to perform any test. I'm going to assume it's appendicitis. Okay? Or kidney stones. Okay? Now, if it's a female, we have additional issue. Okay, ovarian torsion. Ectopic pregnancy. When it's female, you have two additional things that can be confused with appendicitis. Right ovarian torsion. Okay, or ectopic pregnancy. Right ectopic pregnancy, not left. Okay, so in female you have to think of two additional conditions: ectopic and ovarian torsion. And men, think of kidney stones. Kidney stones. Kidney stones can be confused with appendicitis.
Isn't kidney stones like more back? More back?
Which one?
Kidney stones.
Yeah, but it's now the pain is different. Yeah, kidney is located retroperitoneal, but the pain you cannot see, you cannot feel as if it's back pain. You'll feel as if it's abdominal pain. Yeah. Now the other thing is, think of acute appendicitis. Let me give you the issues here. Acute appendicitis could be confused with acute cholecystitis. Okay, with ovarian torsion, with ovarian pregnancy or ectopic pregnancy. And what else did I say?
Renal colic.
There you go. Renal stones, renal colics. Yeah. Okay, so these are very similar, and they're common. All of these are common. So you can't really, but so at least if it's a male, it cannot be ectopic, it cannot be ovarian torsion, it's unlikely to be acute cholecystitis. If it's man, you're going to think of two things: acute appendicitis and kidney stones. If it's female, now you're a little bit more confused. There's more to it. Okay. Now, clinically, if a patient comes with sudden onset of these pains, and the pain is usually, what's the grade of this pain or scale? Yeah, usually not as far as 10. Like usually it's about 7, 8 out of 10. Okay, kidney stone is most likely like about 9 and 10. It's more painful than acute appendicitis. Okay. So that's the thing. What else? What happens to appetite? Decrease or increase? Why?
Because food will
Irritate it, yeah. So you don't want to eat. Very good. Okay, complications obviously. Rupture, peritonitis, right? Okay, so that's complication. Now what else is there any other physical signs that will help you? Very good. Rebound tenderness on physical exam. Rebound. Now let's move on to physical examination. Physical signs. Okay. Not a person complaining of symptoms. Physical signs. Rebound tenderness. What is that?
when you let go, it hurts more.
When you press on the area. Now if somebody tells you it is my left side that's hurting. Okay, in this case it's right? I'm confusing. So if it's left side that's hurting, are you going to press on the left side or right side?
The opposite side.
You're going to start with the painless side. So in this case the pain is where? Right lower quadrant, right? So you're going to start with pressure or palpation or deep palpation of what? Left lower quadrant, and keep getting closer and closer. So as you get closer and closer, and when you press and you let it go, that will cause pain. The retraction of abdominal wall. Pressure will not cause pain on the left side. But then when you let it go slowly, because the wave will go all the way what? The muscle pressure will all the way reach to where? The right side. And when you let it go, the pain will increase. Okay. So that's called rebound tenderness. You don't start, be careful, you don't start on the right side with rebound tenderness, with palpation of appendix, because it's already painful. And when somebody tells you, oh, it's painful, you don't do no more. You have to be careful. Because they're there for you for what? To get rid of the pain. And you don't want to cause them pain. Okay? You don't want to cause them pain. Unless you're in my clinic, you don't want to do that, right? Alright, so rebound tenderness, that's what it is. What else?
There's a test with the rising foot, leg.
Okay, so let's go with the hamburger signs first. We say rising foot. Hamburger, not hamper. Hamburger sign. What's that? It's positive. You don't feel hungry. Decrease appetite. That's why it's called hamburger sign. You tell them, would you like to have a hamburger? No. If this is yes, it's negative sign. If this is no, so no appetite. Now also there's something known as source sign. Obturator sign. Huh? McBurney's point, yes. McBurney's point is the left area. The right quadrant area. So McBurney's sign, you can do that too. Now, for appendicitis, these should be positive. What is source sign? We talked about these two. What does the psoas muscle do? It flexes your hip. It flexes your hip. So when you put the patient on their back and then tell them to put their knees in the 90 degrees and you cause flexion of the knee, the muscle is contracted. It will push against the appendix, inflame the appendix, and will cause pain. So flexion of the knee will cause pain, especially if you flex it and medially rotate it. So the obturator sign is medial rotation of the knee in a flexed position. So this is the knee, like my elbow, right? You flex it and you medially rotate it. You medially rotate it. That's obturator. The obturator muscles, they're known as adductor compartment, right? Obturator nerve supplies all the muscles of your thighs that are causing adduction when you bring your thighs close together. Okay? You know when you go to gym and you have those instruments, I don't know what you call it, you pull your legs together, not pull away, pull together. That's the muscles are supplied by what? By who? Obturator nerve. Okay? So now they're known as adductor compartment. Anyway, so contraction of those muscles will cause pain. What's McBurney sign? Yeah. What's Murphy's sign? Very good. So how does it work?
When you
Yeah, pain will increase with breathing. That's Murphy's sign. McBurney and Murphy are two different things. Murphy is for acute cholecystitis. So in this case it's a differential diagnosis, right? So be aware of that. Because gallbladder can be pushed against the liver with breathing in and out. So that's why Murphy's sign is more significant for acute cholecystitis. McBurney is more common for who? Acute appendicitis. Although they can both occur for both.
isn't Murphy with the phrenic nerve?
Murphy is phrenic nerve, yeah. All right, good. Now, let's say you're highly suspicious this person has acute appendicitis. What are you going to do? Send him home? Surgery. At least do laparoscopic, procedure to see if the appendix is really inflamed. Now, immediately you have to do two things. Don't do diagnosis anymore. Put him on IV fluid and make sure they don't eat anything, and put him on analgesic immediately. That'd be the best thing. Relieve the pain. Let him not eat something that causes pain, right? So give them IV fluid so they don't get dehydrated, and give them analgesic, IV drip. IV analgesic, not oral. Okay, don't give them oral pills because first of all it takes longer, and it's, again, we don't want him to eat fluid or anything, right? It will cause more problem. So at least decrease the pain, and then do laparoscopic procedure to see if there is inflammation, true inflammation. If the appendix is inflamed and it's truly inflamed, you do the procedure. It's maybe you make 3 holes and you look on the screen to see if appendix is inflamed. If it is inflamed, just remove it, no big deal. It's a straightforward, simple procedure. Wouldn't take too long, and it wouldn't take too many complications. And you wouldn't have, in good cases, if you do it right, you might not even have scars in your abdominal area, especially for girls, because they're more, they're sensitive to scars. So you won't even have scars. So in and out procedure. So it'll be straightforward. If it's, huh?
It became more sophisticated now. But like,
yeah. So especially now, there's no issues. Simple procedure. So you can remove the appendix, and then you don't need appendix. As far as we understand today, we don't know the exact function of appendix. So therefore, you're really not losing much. Of course, it's part of your body. You will miss it. You will miss it. I'm telling you, you'll miss it. So for a week, you'll be feeling like, as if there's a part of you missing. So that's fine. That's psychological. But functionally, it doesn't put you in trouble. Okay, so that's it. That's for appendicitis. And if you do laparoscopy and you don't find anything normal, look for something else. Okay, so maybe something else. It's okay. Okay. All right, let's move on to hemorrhoids. Hemorrhoids are venous plexus, normal venous plexus. Okay. So in this case, we have to draw rectum, anal canal. Now, in the wall of rectum, why am I using blue? So let's just use a different color so it's not confusing with So let's say this is a wall of rectum and inner canal. Now you have normal plexus, venous plexus. Above, see, rectum has two parts to it. Okay, rectum has two parts to it. A part of rectum that is, or anal canal has two parts. Sorry, anal canal has two parts. A part of the anal canal that is made of columnar epithelium, and a part of it that's made of squamous epithelium. Okay, that means there's a junction between squamous and columnar epithelium. Okay, so now above this junction is internal anal canal, below that is external anal canal. So now let's say this much of the anal canal, this is external anal canal, and this is internal. Okay, external anal canal is of course external anal sphincter and below. Okay, and there's a line known as pectinate line. You will see this line that there's a junction between squamous and columnar epithelium. That's the division of external and internal anal canal. Why do we even care for that? The reason we care for that is nerve supply. Huh?
It becomes painful or painless.
Excellent. We care for this in terms of nerve supply. Okay, nerve supply. Nerve supply. Nerve supply. Okay. External anal canal, its nerve supply is pudendal nerve. Okay, external anal canal, the nerve is pudendal nerve. But guess what, guys? Please memorize this nerve. Have you heard of the pelvis and perineum? Perineum is all external genital organs. The main nerve of perineum is what? Pudendal. P for pudendal, P for perineum, which is the skin of in all voluntary things of genital area. Okay. In the nerve supply of internal anal canal is sacral plexus parasympathetic, which is S2, 3, 4. Excellent. Excellent. Which is visceral supply. Visceral supply. Now, the visceral colon does not have pain in terms of laceration and cuts. The only pain you will feel is distension. The pain receptor are only responsive to distension and pressure. Okay? That's in colon or intestine. Anyhow, now let's go back to hemorrhoids or hemorrhoids. Hemorrhoid are these normal venous plexus. Venous plexus means, look, this is one vein, another vein, another vein, another vein. They're all merged together. In this area, when they're merging and combining, this is known as plexus, or a network of veins. So you have venous plexus inside the wall of anal canal. Okay, these are venous plexus. They're normal. They're supposed to be there. Okay, they're supposed to drain your anal canal because of toxic substances or let's say waste products and carbon dioxide, and take it back to the heart. Okay, so it's like any other vein, but these are mucosal veins. These plexes are what? Mucosal plexus, mucosal plexus, mucosal plexus, mucosal, submucosal, special submucosal, I should say. Okay, so remember, mucosal layer has submucosal as well, right? It's a part of it. So these are submucosal veins, mucosal, submucosal veins. Good? Are we okay with that? All right. That means they are at risk of what? Protrusion. Protrusion. If they enlarge, they can be protruded where? Into the lumen. As long as they're embedded, hidden within the wall, no big deal. They're covered. It's like you have shelves. You put a balloon in a shelf, and then you inflate the balloon so much that it sticks out of the shelf. Each time you walk, you're going to hit it. Right? Let's say there's a tiny room, a closet, and you have shelves, and you put these large balloons that sticks out of the shelves. As long as they're within the margin of the shelf, no big deal. So as stool pass through, they will not be pushing it out. But if they're enlarged, now stool can push it out of their normal location. They can fall. Okay, so that's hemorrhoid. Hemorrhoid is simply nothing more than venous herniation. Hemorrhoid is herniation of veins. Anal vein herniation. But you have internal anal vein and external. Okay. External one is supplied by pudendal nerve. So when they herniate, let's say, look, in this case, this is herniated a little bit. Let's say there's one more degree, so this is degree 1, and then they can stick out a little bit. 2, they can stick out a little bit more. 3, if it's outside of the anal canal, degree 4. So it depends. Where are they? I'm just telling you the degree. This is not the same thing. So you can have this or this or this or this or all, you know, different degrees. This is the severe case. You can actually see it physically. Physically, if you put the the patient in a position where you can actually visualize it, you will see this dark thing sticking out of their anal canal. Okay, and it's very painful. And this usually affects patient in the ages of 20, late 20s, usually young people, especially men. Okay, but in elderly you can find them too. I'll tell you the risk factors. So, but anyhow, know that internal hemorrhoids are painless. Painless. External hemorrhoids are painful. So that's one thing. Now they can be asymptomatic, but guess what? When stool comes and pushes them out, that means stool can also cause what? Erosion of these veins. They can bleed. So this would be fresh red blood or darkish blood, not red. Fresh dark blood. You will see dark blood that's warm, that's fresh. Now bleeding, if it's painful bleeding, what would you think? External. If it's painless bleeding, what are you going to think? Internal. Done. That's all. So as long as you know these are normal veins found in the wall of your anal canal, and if they protrudes and they're pushed out of their position, they're misplaced, then the problem can occur. Now internal is always painless bleeding, otherwise asymptomatic. External is painful bleeding. Okay, now what are you going to do? You can push them back in their place, ligate them, put them back in there, tie them up, or cauterize them and remove them. It depends what you're going to do. It depends what is the best procedure at that point. So degree 4 is difficult. You can push them back in their place, but again, you might have to change your lifestyle, meaning at least fiber-rich diet, no constipation, no fatty diet.
Dr. Moneer,
Yeah.
portal hypertension.
Yeah. So portal hypertension, by far, one of the most common cause. Okay, one of the most common cause. Now, as a homework, I remember I gave you guys homework. What was that? I remember I gave you guys homework. Super. What is a super antigen, guys?
It activates every single part of the
Did you guys forget about it, or you?
No, actually, Said did answer the question, so
What do you do today then? Somebody else answering does not compensate for you. The idea was when I ask you, so you have to memorize. What is super antigen? Asra, you want to answer? It's okay. Okay. Okay, that's good. Anything else?
It activates your whole immune system.
I wouldn't go as far as whole, but a lot. Anything else? Okay. Now what should I do? What should I do? What should I do? Give you the answer? I'll give you the answer, but then you're responsible for it, because if I don't give you the answer, at least you study. I'm going to give you the answer. Now I'm going to put it on the exam. Okay, I'll put it on the exam. So let me finish with hemorrhoid. Then I'll come back to super antigen. So I'm going to give you one more homework. I forgot now. Oh my God. It was related to this.
portal vein.
Oh, thank you. Now there are veins known as superior rectal vein, middle rectal vein, inferior rectal veins. I want to know which of those veins are responsible for hemorrhoid. Don't answer it for me. It's a homework. I know there's a group of students who don't know. So do some homework. Okay. Anatomy. So now, again, so today's Friday. Please, on Monday, I would like to know what are the veins supplying rectum, sigmoid colon, and anal canal. Veins that are draining that area. Arterial supply you already know. Arterial supply you already know. But still, I need to know the branches. I need to know the branches of inferior mesenteric artery that supply those areas. Okay? And maybe even think of internal iliac artery. So I need to know internal supply, arterial supply, venous drainage, nerve supply, and lymphatic drainage of rectum, sigmoid colon, anal canal. 3 regions. Sigmoid colon, One is bonus. 3 regions: rectum, anal canal, sigmoid colon. You need to give me 4 things: innervation, nerve supply, arterial supply, venous supply, lymphatic drainage. Okay, what lymphatic, what lymph nodes, are there superior inguinal or inferior inguinal or internal iliac? I need to know those. Okay, you have to memorize, especially when we talk about colorectal cancer. Okay, you need to understand them. So that's homework. And then now I'll leave super antigen one more time, but think about it. You know, if you want to understand super antigen, think of T cells, T helper cells, to be specific, T helper cells, and antigen presenting cells. How did they interact? Think of those two. T helper cells. To understand super antigen, there should be T helper cells. And there are another group of cells known as antigen presenting cells. For example, macrophages. Okay, macrophages. They have to do it. So antigen presenting cell will present the antigen, just like when you present me something like, hey, check this out. Okay, antigen presenting cell will present this antigen, and T helper cells have on the surface something known as TCR. Green is TCR. This stands for T cell receptor. And then you have MHC 2 on the antigen presenting cells. So super antigen have to do something with this. That's enough clues. Okay, that's enough clues. So that means it bypasses this process. So if you know this process, you'll be okay. Okay. All right. Okay. Now, at the end of the day, hemorrhoid is nothing more than painless bleeding or painful bleeding, and drinking alcohol for hypertension is a huge risk for this. Also, obesity, constipation, okay, is a risk factor for this. In addition to that, viral infection, homosexuality or anal intercourse, all of those are risk factor for them. Okay, anything that can misplace these venous plexus, especially if the portal hypertension will cause what? Increased pressure in these veins. They will engorge, they will dilate, they will swell, and they will be protruding into the lumen. Isna. You speak so calmly, now I'm falling asleep. What's the difference between what?
Piles and hemorrhoids.
Piles? Mm-hmm. Large hemorrhoids. Yeah, and they can be actually sometimes infected. Yeah. All right. Now, okay, what are you going to do? Treatment is replace them, burn them, remove them. Okay, those are the things. But lifestyle modification would help. Let's take a break. What time is it?
Would that cause cancer?
No.